Good morning. It's a pleasure for me to be here. And again, I want to join my colleagues in thanking the senators as well as Mr. Michael Botticelli for the opportunity to come and speak with you today, actually on the science of addiction. I'm going to be focusing specifically on what research has taught us about why we humans consume drugs of abuse and what are the effects of drugs of abuse in the human brain. But I want to start with these very obvious slides that show numbers that many of you must have heard many a time, which is reflect the impact of substance use in our country. It is estimated that approximately 25 million Americans, 9.4% of those 12 years or older, have abused an illicit drug during the past month. 137 million Americans, that's 52.2%, have reported drinking alcohol in the past month. And 66.9 million Americans, that's 25.5%, have used tobacco during the past months. I mean, so these numbers are extremely large, if you can think about it, more than half and more than 1/4 for alcohol and tobacco, respectively, and 10% for illicit substances. But I want you to think about those numbers. If you look at it, I'm just going to make the point that the prevalence of these drugs is much higher for the illicit than the illicit substances. And this actually, I'm just going to make the point, is not because alcohol and nicotine are more pleasurable or rewarding, but they are illicit drugs, and that determines the patterns of use. Now let's look at the economic consequences. They are devastating. More than $1 trillion a year from the cost associated from drug use. And you have there divided by the type of drug. For illicit drugs, it costs us $193 billion a year. Alcohol, $235 billion. Tobacco, 193. And it's not that alcohol and tobacco are more dangerous than illicit substances. Again, I just make the point, the reasons why those numbers are much greater than those of illicit substances that combine multiple drugs is the fact that they are illicit. And I want to reiterate this because it is, like Mike Botticelli had said, data alone is insufficient for policy. But we certainly cannot ignore data when we're thinking about generating policy that affects public health. We have the numbers in front of us, and that's all I'm going to say. Now, we now know that addiction is a disease of the brain. And in the past, it was basically dismissed as a problem of moral turpitude, of lack of self-control, of basically a choice on one's behavior. With access to imaging technologies that allow us to probe how the human brain is working, we can now actually identify the areas of the brain that are affected by the consumption of drugs, just like we identify the areas of the heart that are damaged when one suffers a myocardial infarct, which is illustrated in this particular slide. You see the area of the heart that's damaged as compared to a normal heart. We use the same technology. You can see the area of the brain that's damaged from repeated drug use as opposed to a normal control. Here, the damage of this piece of muscle in our heart interferes with the ability of the heart to pump. Here in the brain, the damage to this area of the frontal cortex interferes with our ability to exert self-control. And you're going to be hearing me come back to this notion about the fact that in addiction, a fundamental dysfunction is disruption of the areas of our brain that allow us to exert control of our emotions, our behaviors, and our desires. We now know also that drug addiction, substance use disorders, are developmental disorders. They start, unfortunately, very early on the life of an individual, therefore impinging on its consequences later on throughout their whole life, as opposed to diseases that tend to affect us later in life, such as the neurodegenerative diseases like Alzheimer's and dementia. Now, this has implications from the perspective, certainly, of prevention, because as illustrated in this particular slide, the greatest risk for experimentation on drug taking, as well as the greatest risk for transitioning from experimentation to the loss of control that characterizes addiction, occurs during adolescence and young adulthood. Thus, for interventions that we can for interventions to have a big impact in substance use disorders, we need to recognize that we have to target the young children, adolescents, and young adulthood in order to actually prevent these transitions from happening. We also now know why is it that drugs can produce addiction. We now know that chemically all of the drugs of abuse that produce addiction, whether they are legal or illegal, biology does not discriminate into legal or illegal. They all have a common effect in our brain. They release dopamine in brain reward regions, activating them. And in as much as the activation of reward regions motivate our behavior, this gives us an understanding about why drugs of abuse, when repeatedly utilized, can create such a great havoc in disrupting the motivation of an individual towards drug taking and away of other behaviors that would be much more beneficial to that person. Here we have the activity of drugs, all of the drugs, legal, illegal, increase dopamine in the nucleus accumbens, main reward region. And this is the mechanism by which nature and biology ensures us that we do behaviors that are necessary for survival, such as sex for reproduction or food for eating. This is the way that nature increases dopamine when you get exposed to food or rewarding stimuli, and that motivates your action. Drugs hijack that system and in a much more potent way, producing adaptations that ultimately lead to the loss of control that you see in addicted individuals. So while we understand that actually all of the drugs increase dopamine, and they do it by different mechanisms. In this case, cocaine, its action is it just inhibits recycling of dopamine. So dopamine is liberated, it's recycled back. This recycle terminates its action. Well, cocaine interferes with that recycle, dopamine accumulates, and then there's the pleasurable responses. Nicotine does it differently, alcohol does it differently. Regardless, all of them activate this system. However, with repeated use, the brain adapts to these stimuli, and it adapts whether it is cocaine, alcohol, nicotine, marijuana. And as a result of that, for example, whereas you have the system, a normal system where dopamine is liberated, interacts with these receptors that then transmits the signal, when someone is taking large quantities of drugs, the way that the system tries to compensate is by decreasing these proteins here so that that can attenuate the strong signals that are generated from drugs. And indeed, what you can see across a wide variety of drug addictions, whether you do the studies in animals or in humans, now we can do it with imaging technologies, you can see whether it is cocaine, methamphetamine, alcohol, heroin. When you compare them across normal controls, you see a reduction in these dopamine receptors, which are localized in the center parts of our brain. And it's a very, very consistent finding, and as I say, has been seen both in animals and in humans. And it's actually an interesting concept because it identifies one single protein, a biochemical change in the brain of people that are addicted, a reduction in a receptor that actually modulates the vulnerability for their capacity to control the urges to take more drugs. When these receptors are down, individuals are impulsive, and they have a propensity for compulsive behaviors. And in animal models, for example, where we can do gene therapy, where we can inject the gene that is encoding for this receptor, such that we can bring, in an animal model, those receptors up. We can actually, regardless of how you do it, observe that when you do that, when you increase these receptors, you dramatically reduce the consumption of high doses of drugs. So if you manipulate it in such a way that you can actually increase the signaling from these receptors, you decrease the propensity of those animals to consume the drugs. So clearly, we have identified a biochemical change that is making the brain of individuals vulnerable for compulsive drug consumption, which is one of the characteristics of addiction. We have actually, studies have gone on and to try to understand why. Why is it that this simple phenomena of reducing one protein in our brain, and there's more than 100,000 proteins in our brain, one of them can produce these consequences? Well, now we know from multiple studies that the reason why these decreases in receptors have such deleterious effects is that they are regulating the frontal cortex of our brain that actually I started with by saying are crucial for our ability to exert self-control of our behaviors, emotions, and desires. As these receptors go down, like in this, the activity of these areas of the brain, the prefrontal cortex, goes down. What's interesting is that the prefrontal cortex allows us to do judgment, to make decisions, and to carry them through. So if you start to think about it, repeated exposure to drugs is interfering with the function of the frontal cortex. You can then start to also understand not just the propensity for compulsive drug administration, but the propensity for impulsive act and improper decisions that can end them up in jail or making decisions that can be quite catastrophic for their own lives. We also know that drugs does not equate addiction. Not everybody that gets exposed to drugs responds in the same way. Not everybody that gets exposed to drugs becomes addicted. Some people are more sensitive than others. And we know that genes are very important. We know that there is a significant contribution of genetics and heritability in the process of that transition from drug experimentation into addiction. But we also know that development is very important. The younger you start taking drugs, whether it's alcohol, marijuana, or nicotine, the greater the vulnerability that you will transition into addiction. And we also know that environment is crucially important. And for prevention, this is extraordinarily relevant. Because while we currently cannot change our genes, we can do interventions that can prevent the adverse effects of environment. And we've known all along that social stressors are some of the most important factors that can mold the vulnerability of a child or adolescent into a trajectory of substance use disorders. The greater the number of adverse social stressors in an individual's life, the greater the risk of transitioning into addiction. In such a way, and this old study, showing that kids that have had 5 or more adverse exposures to stressors, and these are the exposures, had 10-fold greater risk of transitioning into addiction. Again, highlighting the importance of social environments. Scientifically, why? Why is that so? What is a social stressor during childhood doing to your brain or our brains that is making them more vulnerable? Again, now with technologies, we can actually start to probe that. And this is one of those examples. This is a study that actually measured the same dopamine receptors I was speaking about that modulate your vulnerability for compulsive drug taking, for impulsivity. These are animals that are actually geared all of their life, geared in isolation, one animal per cage. For any one of us, primate creatures, it is highly, highly stressors, highly, highly stressful. When those animals then, when brought into a group environment, multiple animals to a cage, the investigators repeated the measures of dopamine receptors in the brain, and what they showed was those animals that became dominant increased the level of receptors from very low levels to high levels. Those animals who became subordinate, and being a subordinate is very stressful for a primate, those animals, the receptors did not go up, and in some of them actually became lower. And when they tested these animals in their propensity to administer cocaine, they find that these animals in whom the transition had increased the levels of dopamine D2 receptors, they did not consume cocaine. Whereas those ones in which the dopamine D2 receptors remain low readily administer high doses of cocaine, showing how an environmental intervention can profoundly influence the expression of dopamine D2 receptors, documenting how important our environments are in molding the biochemistry of our brain, but in this case, specifically in influencing the expression patterns of a receptor in our brain that actually, when it's low, conveys vulnerability for compulsive behaviors and impulsivity, and when it's high, provides resilience. So the lesson to be learned from that is, as we think of prevention, how do we then intervene to protect those children that, because of their nature of their environments in which they are born at, are going to be at much greater risk of substance-taking behaviors because of these adverse effects of social stressors in our brain. And this slide is just to illustrate that a similar phenomena has been documented in humans. So similarly, social stressful environments can modulate the expression of dopamine D2 receptors in the human brain. This is another study just to illustrate how social stressors, and I'm again emphasizing social stressors, are particularly negatively influencing behavior when they happen during childhood and adolescence. And in this study, what they are measuring is the connection between the frontal cortex and our limbic brain. And it is this connection that actually allows us to control our emotions. And what these investigators found was that in children that have been reared in an orphanage, which is highly stressful, these connections are weakened, and the longer they stay in the orphanage, the weaker the connection. And the weaker the connection, the less your capacity to exert cognitive control and decision-making into inhibiting and regulating your emotions, which of course then puts you at much greater risk to a wide variety of behavioral disorders of high risk, including drug addiction. The good news and the important news is that drug addiction and substance use disorders can be prevented. And theoretically, they should be fully preventable. If we don't have drugs, if the individual doesn't get exposed to drugs, they will not develop. And that's very, very different. We know that. And you sort of say, well, that's obvious. But it's not obvious. Imagine if we had an understanding of what are the factors that are leading to Alzheimer's disease. Imagine that. Would we not do everything we can to prevent exposure to them? I'm just going to let that question hang out there. We know, in the case of drug addiction, we know drugs. So if we interfere with the exposure of drugs, or if we do interventions that will prevent kids from wanting to take them, we will affect their behavior. And this data show from Monitoring the Future shows two graphs that have been collected since 1975. One of them is past year of marijuana use in 12th graders, 17 to 18 years of age. And in blue, you have perceived risk, the number of kids that perceive the use of marijuana as risky. And what you can see, they are opposite mirror images. As more kids perceive that marijuana is harmful, you have less use. And as less kids perceive marijuana as harmful, you have more of them taking marijuana, indicating, indeed, that kids are sensitive to the perception of how the drug is going to influence them. Kids are also very sensitive about the perception of whether others are using it or not. And if they think that they are, they're much more likely to use them than if they are not. So we know what variables we can use in order to minimize experimentation with drugs. And we also know what variables to do, what prevention measures work and strengthen and can provide resilience from from kids taking drugs. Multiple studies have been done. I say it is actually quite simple to summarize them. Reduce all of the risk factors, elevate all of the resilience factors. And those are multi-level factors that we can influence. At the individual level, an extraordinary important one is doing interventions that will increase self-control. And there's multiple evidence to show that this actually can be done. It's much harder, for example, to do interventions that will increase the classical IQ. But there are interventions that have consistently been shown to improve self-control. There are also family interventions that can provide resilience, peer interventions, school, and community. And then are all of these factors that we know are associated with much worse outcomes. So we have the tools. We have the knowledge of how to do it. We just need to implement. And this is just to illustrate, I mean, it is study after study after study. The greater the self-control, the lower the likelihood that you will have not just substance use disorder, but also overall adverse health outcome. And these are some of the interventions that actually have, for which there is independent evidence that they can actually improve self-control in children and adolescents, which in turn will improve their outcomes vis-a-vis substance use disorders, vis-a-vis health, and vis-a-vis educational achievement. So in other ways, really it's a non-brainer vis-a-vis how important these interventions can be for outcomes. And the other good news is drug addiction can be treated. The bad news is, as of now, we don't really know how to cure it. But we can treat it, just like we treat a wide variety of chronic diseases. And in this case, you see an individual whose actually treatment and rehabilitation program, which was through a drug court, not only resulted on this person being able to be stopped taking drugs for 14 months, but you can see the recovery in their brains. The brain is resilient. It has plasticity. It can recover. But we do need to do interventions to facilitate, accelerate this process. This is just to illustrate what we've all heard along, that even though we now know that treatment works and it improves the outcomes in individuals, despite that knowledge, the access to treatment is very limited. And the involvement of the healthcare system is also very, very limited. And this, again, is a missed opportunity to improving the outcomes of those that are suffering from substance use disorder. This is a slide, actually, that came out of a concept from Dr. McClellan, who eloquently showed one of the reasons why the healthcare system has not been very active at all in the treatment of substance use disorders, and what has justified why, the justification that is being used of why they should have not been paid for, insurance should not pay for. And he shows it in hypertension. You can see that if you treat someone, they recover, their blood pressure goes down. If they stop, their blood pressure goes up, and that's used to justify that the treatment works. In contrast, in addiction, if you treat someone, they stop taking drugs, but then when you release with no aftercare, no surprise, they go back to taking drugs. But this is actually used to justify why you shouldn't be paying for treatment because it didn't work. The moment you stop treatment, the patient relapses. It's a chronic disease, and that's what the message is about. You cannot expect that 3 weeks or 4 weeks of treatment are going to cure addiction. We don't know how to cure it. We treat it, and we treat it as a chronic disease problem. So I want to end up my slide by saying we have an incredible opportunity with all of the changes in the parity law, in healthcare reform, to provide for the first time access to healthcare to individuals that have substance use disorders that in the past did not have it. Our success, though, will require that we actively engage the healthcare system and make the public aware of the notion that substance use disorders are not the result of moral failure. They are the result of changes that occur in the brain because of genetic, environmental, or developmental issues. And that we have the opportunity to prevent them and to treat them. Thanks very much.